Good morning. Great to be here. Thanks for coming to Cleveland. Where's my little here? All right, we're going to talk about POEM and POP. While I show my disclosures, how many people do third space endoscopy already in their practice? That's awesome. Okay, that's great. Is that 7 seconds? I think so. All right. This obviously has changed everything that we do. So when we look back at the history, I love history, okay? As I get older and older, I love knowing what happened before me, okay, as well as what I've done. But Heller's been around for over 100 years, and now we know that POEM's been around since about 2008 is when Haru first came up with this idea. But again, there's a definite history to this concept of taking care of achalasia. But this is really where all of our third space stuff started, is when we decided to put scopes up people's different holes in their rectum and their vagina and down their mouth and do notes. And this was the very first IRB case that Dr. Ray Anders and I did, where we're putting a scope in the peritoneal cavity to take out a gallbladder. It didn't make much sense. We abandoned that concept, but what it did do is it gave us this idea, and this is from Raj Pashrika, who came up with the idea of investigation of esophageal, periesophageal tissues. He was looking for lymph nodes, saw the muscles, said, hey, I wonder if we can do a myotomy at the same time. And that's, again, where now Haru Inoue, who was a thoracic surgeon, he was in Yokohama, now in Tokyo, was the very first person to do a POEM in 2008. He had also invented ESD. So for those of you that are surgeons, nothing against our GI people, okay, but for the people that are surgeons, this is where most endoscopy things come from, okay? I mean, PEG, you know where PEG was invented? Here in Cleveland, right? A couple pediatric surgeons, okay, and Dr. Ponsky. But anyways, Haru came up with the first case of doing a POEM, and now probably 20, 30,000 cases around the world have been done this way. Heller, how many people do Heller myotomy still? Okay, I'll put my hand down. Before doing POEM, I had done 2 in my entire life. And since then, I don't do them anymore because I don't think I was skilled enough, and I give them to my partners. But it's a simple procedure, whether it's done laparoscopically or robotically. It's effective, but it is abdominal surgery, all right? And now when we look at POEM, it's not abdominal surgery, all right? It is something through, obviously, endoscopic therapies. There are some definite disadvantages that we have to look at, and one of them being, obviously, the effectiveness and the durability, as well as the issue of reflux. All right, so when we look through some of this series, Sal, I put your name on here, okay? This is a study that Sal did while he was with Eric, and basically looking at the POEM. We know that endoscopy versus surgery is probably going to be less painful. You're probably going to have a shorter length of stay, but it's really hard to compare these things because length of stay for Heller is going to be a 24-hour thing to begin with, okay? And most people nowadays aren't giving narcotics for anything that we do. When we look at the North Shore, or not North Shore, I can't remember what Yujiki's place is called now. But anyways, Mike also did a study looking, again, at quality, okay, for these patients. And it's there, all right? When we can do something endoscopically versus surgically, we're going to find a quality of benefit of life. And the type 3 people, again, from the abdomen, maybe you can reach up 5 or 6 centimeters, but obviously from the mouth, we can go as far as we want, from the upper esophageal sphincter all the way down. Another study from Yujiki's is that pain, again, just like what Eric and Sal had shown, was better. Return to activities was probably improved. And dysphagia and Eckhart scores are similar. Whether you cut the muscle from the outside or the inside, it's probably the same kind of concept. All right. What else do we know? You're going to hit about 90%. The same way that endoscopic therapies for reflux hit a 70% plateau and getting rid of PPIs. I think all of the things that we're doing for achalasia are probably going to be 90%. And I've learned over these last about 14 or 15 years that achalasia is the gift that keeps on giving, okay? It's like being a vascular surgeon. These people never will be out of your practice, okay? Kind of like hernia stuff as well. But anyways, in this study, okay, out of Northwestern, again, 90% seems to be what our successful treatment seems to show. In the European study here, again, what they served, when they did a randomized trial, well, not randomized, the comparative trial, okay, of POEM versus Heller, they both hit about 80%, all right, which is interesting because I think we're seeing 90% in most of our series. Adverse events were less for POEM, but the problem is if you look at the bottom line, the rate of endoscopic identified esophagitis was definitely higher in these POEM patients at 3 months, okay? When you look later, though, when you come back 2 years later, the rates are more similar, okay? And so I think Heller, no matter whether you do a door or a toupee or whatever, there is a reflux process that comes when you violate that lower esophageal sphincter, and I think things equilibrate a little bit more so. In terms of the one meta-analysis that came out, and nothing against Dr. Potty, wonderful surgeon, okay, and we support him for all the things he does. Maybe not a big fan of POEM, okay, but when you look at this meta-analysis and you dissect things out, it's about 5,000 patients, okay, but when you compare things, yes, POEM did better in terms of dysphagia. POEM and Heller by symptoms were similar, okay, but when you looked in his series, okay, at the positive pH studies, POEM was 3 to 4 times higher. But when you dissect the patients that actually had objective testing, okay, it's amazing. Less than 0.25% of the Heller patients actually had a Bravo, okay, but yet they're saying that the rate of reflux was similar. So I just think we have to be careful when we say that Heller doesn't cause reflux as well. So I think it's safe. We're going to keep going on. Finally, gastroparesis, again, another muscular-based disease that we can address, diabetes, idiopathic, post-vagotomy, kind of things that we can address. We've been doing POPs. I don't see as many gastroparesis as I see achalasia. We make a much shorter tunnel, but same concept, okay? We're going to work in that third space. And when we look at the series out of the clinic here with J-Rod, with Dr. Rodriguez, they had a huge series of patients, and it works, okay? And you get to about 70 to 80% success rate, okay? But the people that it works best on are the diabetics, maybe the idiopathics. Our post-esophagectomy patients, or those after Heller or Nissens that get gastroparesis, it's a little bit harder to get those good effects. But anyways, in conclusion, learn the third space. It's a great place to work. These things are effective. It's not that complicated to do these things. If you can hold an endoscope, you probably can do these procedures. Thank you very much.